We put this program together in May, which is in recognition of Brain Tumor Awareness Month. So we're glad that you're all here with us, and I would like to introduce our speaker for this evening, Dr. Andrew Chi, who is an assistant professor in the departments of medicine, neurology, and neurosurgery. And he is also the co-director of the NYU Langone Brain Tumor Center and the director of the neuro-oncology program here at NYU. He's a very busy guy, but we're very excited to have him here tonight. So let's welcome Dr. Chi.
So thanks everyone for coming. It's a really nice, but actually it's a little too hot for me in general, and it's going to get that way probably for the rest of the summer. Hopefully it cools off by the time we leave here. So I'm a neuro-oncologist, which means I'm actually myself a neurologist as well as a person who treats brain tumor patients and can give chemotherapy. If someone needs chemotherapy. So there are people who treat brain tumors who are neurosurgeons and also medical oncologists who trained in just general medical oncology, and then they give chemotherapy to brain tumor patients. So I am a neurologist, and I can manage patients with neurological disorders as well as oncology, which means I can give chemotherapy. So I'm just one of the facets of all the different disciplines that treat patients with brain tumors. So that's my role. And then the other thing about brain tumors is brain tumors actually are not very simple. So the WHO, which is the governing body that establishes the diagnosis of a brain tumor and what they are, actually recognizes over 100 different types of brain tumors, ranging from completely benign to malignant. And so when you say brain tumors, people may or may not think of one or two things, but actually there's many, many, many different kinds. So really, if I wanted to talk about all brain tumors, it'd be way beyond the scope of an hour, hour and a half. It would take, basically a whole semester of a college course or something like that. So I'm not going to do that. Still, what I want to do is introduce brain tumors in general and give the principles of essentially how we diagnose them and manage them in the broad categories of each one, and then also introduce our cancer center here and our brain tumor center and how each of our different disciplines are working together to help treat patients with brain tumors again, and I'm just one arm of that as a neuro-oncologist. With that, really, there's multiple different disciplines and specialties, ranging from MDs to all the other specialties as well, that are involved in caring for a patient with a brain tumor, and I've just listed some of them here. So there's the radiologists who interpret our scans, the surgeons, of course, that do the surgery for patients with brain tumors. There's radiation oncologists who are physicians that help provide the radiation therapy to patients with brain tumors. Radiosurgery is called radiosurgery, but actually it's radiation, but a very specialized type of radiation. Neuro-oncology means the people that actually give the chemotherapy and provide the medical management, which is what I do. We have different centers that coordinate all this. For example, I'm part of the adult neuro-oncology centers. We have a pediatric neuro-oncology center. We also have something called NF Center, and I'll explain that in a little bit. There's this specific type of disease called neurofibromatosis, where many of them get brain tumors, and we have a center for that. In addition, the pathologists who do the actual diagnosis of the tumors work in the background after we do surgery to figure out what exact type of tumor patients have. And of course, really being an academic institution and a research center, we have a whole arm, a background amongst all of this where we do research in brain tumors using patient specimens, also using other laboratory techniques to understand more about brain tumors and develop new therapies for them. And really, these disciplines are just listed, are sort of the physicians that I've listed here, but in reality, there's an enormous team behind each one of these disciplines to make each one of these things work. So teams of nurses, technicians, physicists, medical assistants, all sorts of people that really, to care for a patient with a brain tumor or any kind of cancer requires really an army of multiple disciplines across all fields to take care of them. What I listed here is as neurology, for example, we often ask our other colleagues to help manage for other complications that patients have with brain tumors like seizures, et cetera. And then we have a whole supportive oncology network ranging from social workers to psychiatrists, as well as integrative health, where people can go to get other therapies, including acupuncture, nutrition, et cetera, and things like that. So really, this is, it seems like a lot here, but this is just a small representation of what it takes to care for a brain tumor patient really in the best way. Who we are, just in terms of some of the directors and leaders of our individual brain tumor center, are really listed here. Myself and John Golfinos, who's the chair of neurosurgery, really lead this whole team that we've put together to care for brain tumor centers, for brain tumor patients. But again, we have all of these different disciplines, and we have people that lead each one of these different arms of all of those groups. What are brain tumors? So that's just a general introduction to the team that takes care of brain tumors. And I'll go into a little bit about each one of those teams when we talk about how we manage patients with brain tumors. So again, as I mentioned, brain tumors, there's not really one or two types, there's really 100 different types. And when we say brain tumor, actually, what we're talking about in general is the brain and spinal cord. Really, the brain and spinal cord are all connected. They're part of what we call the central nervous system. So the brain and spinal cord are all connected in their own, in essentially one organ, covered by their own shell, so their own skin, bathed in their own fluid, really. And tumors that arise in the central nervous system tend to be generally called central nervous system tumors. And they generally tend to be related in some way or another. And so these are, when we say brain tumors or neuro-oncology, we're really principally talking about brain and spine tumors. And even with that limitation, there's a whole host of tumors. These are the sort of four broad categories of the type of central nervous system tumors that we see and treat. We think of tumors as being malignant or cancers or benign, but see, even the term malignant or cancerous in a central nervous system tumor is not the same as when we think of cancer or benign tumors in other parts of the body, for example. So when we think of a colon cancer versus a colon polyp or a benign tumor, there's a very sort of defined way we think about them. So for example, you can have a colon polyp that's a completely benign tumor, and it might just grow, and if you just leave it alone, it might just continue to grow. If you take it out, they're 100% cured. But if that tumor ends up spreading, it can spread to other parts of the body, including the liver, lungs, etc., and then it's called a cancer, and those are malignant tumors, right? So there's a very clear distinction between benign and malignant in other cancers of the body. Now, in the brain, it's extremely rare, although not never, but it's very rare for a brain tumor to leave the brain and spinal cord, so to leave that central nervous system and go to another organ, like the lungs, the liver, and therefore they're technically not metastatic cancers. So the term cancer is, when we think about cancer in the body, it means they've spread to other organs of the body, they're cancers. But really that doesn't happen to brain tumors. They can spread within the brain and spinal cord, but since they don't spread outside the brain and spinal cord, we technically can't call them cancers. But if they spread throughout the brain or the spinal cord, they can be deadly tumors. So they're essentially cancers. There are brain tumors that are actually technically benign, meaning if you completely resect them 100%, then maybe 98, 99% of the time, essentially you've cured them. But sometimes there are tumors that are not resectable. They're in very deep locations in the brain and you can't take them out. And they may be 100% benign, but if you can't take them out and they continue to grow, and we have no way to treat them, they can also be deadly tumors. So even benign tumors can be, quote, malignant in the brain and spinal cord. And so the terminology for what is a malignant cancer in the brain and spine is very different from the way we define them in the rest of the body. So how we define them technically is there's malignant tumors, and these are tumors, these are some of the names that we have for malignant tumors of the brain and spinal cord: glioblastoma, glioma, medulloblastoma. And these are some what we consider benign tumors, and these are meningiomas, acoustic neuromas, pituitary tumors, things like that. Some of these you may have heard about, some of them you may not. But again, some of these benign tumors can act very malignantly if you can't take them out. Then there's a whole other category of brain tumor called metastatic brain tumor. And actually, in reality, those are the most common brain tumors. So about 5 to 10 times more metastatic tumors happen than tumors that start within the brain itself. So what a metastatic tumor is a tumor that started in another part of the body, like the lung or the breast, and they spread to the brain, and that's a metastatic tumor. And there's 10 times more of those than primary brain tumors. But they are still brain tumors, and they require very special attention with all the same disciplines that I just mentioned before. And then there are other unique brain tumor syndromes. These are genetic disorders that happen to people. These are certain genetic disorders that tend to affect the brain and spine preferentially, and we see a lot of that because some of these genetic disorders, and neurofibromatosis being one of them, is really one of the most common genetic disorders that we see in the population. And I'll go into a little bit more detail of some of the more common ones that we see here. So here are some representative images of some of the tumors that I talked about. So malignant brain tumors, these are what we consider cancerous. And we consider them cancerous because they tend to spread throughout the brain or the spinal cord. And if you can't treat them, that spread can become essentially lethal. So glioblastoma is shown here. Of all of the brain tumors that we see in adults, all of the malignant brain tumors that we see in adults, glioblastoma is unfortunately the most common. It's actually, of all the tumors that we consider malignant in adults, glioblastoma is the most common. It's about 2/3 of all the malignant tumors that we see in adults. And what they are this is a picture of one. What happens is all the bright stuff around the edges are where the tumor cells lie, and what they do is they invade the surrounding brain. And although it looks like a big tumor, in reality it's actually not a tumor mass. Most of this dark area on the inside of this tumor is actually really dead tissue. It's really what we call necrosis. Necrosis is a technical term that in medicine we call essentially dead tissue. And so what happens is these glioblastoma cells, as they invade into the brain, they leave a trail of essentially what we call dead tissue. So it's actually really the actual tumor mass here is actually not very large, but the area of brain that it's actually basically injured is actually quite large, and it can lead to a lot of neurological dysfunction. If you can imagine, if that process continues to go on and on and on, it can eventually lead to very serious problems. Now, there's another type of glioma. When we call gliomas, so the reason why we call them gliomas, and glioblastoma being the most aggressive kind of glioma, we call them gliomas because the brain is made up of a lot of different cells, but if you think about it, an easy way to think about it is the brain is principally made of two general cell types. The neurons that do all the firing and communication and help you actually think are one type, and those are that generate the nerves that go to the rest of the body. And then there are all the support cells of the brain, and the support cells are called glia, and they help the neurons do their thing. And if tumors arise in the brain, by far more common, they arise from these cells called glia. And so therefore we call them gliomas, because under the microscope they actually look like glia. So that's where the term gliomas come. But there's many, many different types of gliomas, I should say. And when they arise and they are what we call low grade, and when we say low grade, they grow relatively slowly. Versus glioblastoma, these are also glia derived, but they grow very, very quickly. So there are more low-grade gliomas, and there are also very high-grade gliomas. They grow very quickly, and these are glioblastomas. So low-grade gliomas, although they grow slowly, they often still grow over a period of years, and they tend to occur in younger patients that are in their 20s and 30s and sometimes early 40s. And although patients may live longer because they grow more slowly, the median survival of patients with low-grade glioma tends to be somewhere around 6 to 10 years, which may or may not seem like a long time when you ask different people, but to a 30-year-old, which is the typical age of diagnosis of these tumors, it's actually an incredibly short period of time. So these are actually still malignant tumors where under the microscope they might have somewhat benign features. Medulloblastoma is another type of brain cancer that we see occasionally in adults, but actually it's the most common malignant cancer that we see in children. These tend to occur in basically children, usually less than 3 years old. They can actually occur in children up to 10 years old. And they arise in the bottom part of the brain. They're extremely fast-growing tumors. Now, fortunately, most kids with medulloblastoma can be cured with a combination of radiation and chemotherapy. About 3/4 of patients, kids with medulloblastoma can be cured, which has been a remarkable success in cancer therapy. But we cure them using techniques that sometimes cause a lot of harm. So chemotherapy can sometimes be very difficult to take for kids, but radiation therapy in a developing brain and a developing spinal cord can lead to long-term damage in some of these kids. And so they often grow up and they have cognitive delay and other hormonal and cognitive problems as they get older. So these are really the principal types of malignant brain tumors that we see and treat in the brain tumor center, and most brain tumor centers and principally here at NYU. Now, actually, so fortunately, the malignant brain cancers are not the more common ones. So we see about 10 times more of what we call these benign brain tumors in adults than we do the malignant ones. So here are some examples of what we consider benign brain tumors. Meningiomas. So meningiomas are tumors that arise in the the skin around the brain and spinal cord. So the brain and spinal cord are bathed in their own special fluid and are protected by their own skin, and because our brain and spinal cord are extremely important organs. And that skin and fluid serves to do a lot of things to protect the brain and spine. So when you take drugs or get exposed to certain toxins, that skin, which is called the meninges, helps basically keep those toxins out of the brain and spine, so you don't get, your brain doesn't get toxicity from them, or it pumps them out actively. But tumors can arise from that skin, so those are the meninges. And so when tumors arise from that skin, we call them meningiomas. They're often benign. About 70-80% of the meningiomas that we see are actually benign, meaning if you take them out, then essentially about 95 to 98% of the time, this person will never have to deal with that tumor again. They're almost like you sort of just benign growths on your skin, your actual physical skin, and if you take them off, you'll basically solve the problem, never have to deal with it again. But about 20% of these are what we call higher grade, and they have a propensity to come back. And when they come back, we have several measures to deal with them. But again, even though they're benign tumors, they can often occur in very deep locations where we can't do surgery, and then they become a problem. Another one that's actually fairly common is called an acoustic neuroma, also called a vestibular schwannoma. And these are tumors, this little sort of triangle-shaped wedge here on both sides, those are the nerves to the ears, actually, and they come out from the bottom of the brain. And along those nerves, the sheath along those nerves can develop tumors as well. And here is an example of a very large tumor that's arisen from that sheath. And they can result in hearing loss and also paralysis of part of the face. They're benign tumors, but again, they can often be very difficult problems to deal with if surgery becomes a problem. Another type of tumor that we commonly see, and these are often considered benign, are what's called pituitary tumors. So here's a different view of the brain. These are actually three different views of the brain, which I should have mentioned. This is a view of the brain, the front, back, left, and right. And this is a picture going like this. So if you just take a picture and slicing it like this, that's what we call an axial view of the brain. This is a little bit lower view of the brain, where you can actually see here the eyes and the nose and some of the sinuses in the back of the face. And then down here, these are the nerves to the eyes. And then this is what we call a different view of the brain. So if you take one here, this is called the sagittal plane. And here you have your nose, the mouth, and some of the deep sinuses. And just really behind your nose and the deep sinuses sits a gland called the pituitary gland, which expresses a lot of very critical hormones that your body uses to function normally. And tumors often arise from that pituitary gland. And what you see here is this white area with this tumor sort of jutting out and growing up into the brain substance itself. And these can be often really cured with medical therapy or surgery. But again, for all of these tumors, there's a subset where treatment is a problem, where they keep coming back or they're just not in accessible locations. So these are some of the benign tumors that we see in the brain. So, and then some representative pictures of what we call metastatic tumors, and then this genetic disorder called neurofibromatosis. So brain metastasis, here's a picture. Really, what it is that, for example, lung cancer, this is an example of a lung cancer. When they spread through the blood and they go into the brain, and because of that, they can really land in any part of the brain, and where they land, you see these tumors. So here's one patient with 2 tumors, but they can literally be 2, 5, or even dozens of tumors in the brain when they spread to the brain. Here's what the neurofibromatosis is, that genetic disorder that I talked about, and they tend to cause what we consider slow-growing benign tumors, but they can arise really in any nerve or really in the brain or spinal cord in the body, so brain, spinal cord, and even in the nerves that come out of the spinal cord. So what we have here, this is a picture, this is actually a picture of the hip, and these are the pelvic bones, and these are, this is the hip joint here on both sides, and this is your femur. These are the leg bones that come down. And these bright spots actually should not be there. These are all benign tumors. Actually, this area should look very much like this. And what you see here, these are all very large benign tumors. So these patients with neurofibromatosis just develop these big tumors really all over their body. Every nerve develops a brain tumor. And as you can see, this is not a problem we can fix by surgery, and really not a problem we can fix by doing radiation even. So what we have to do in situations like this is treat each one of these tumors selectively as or when they cause problems. Another type of neurofibromatosis, and I showed you those nerves to the ears here, and people can get these, what I called before, these acoustic neuromas or vestibular schwannomas, these benign tumors that arise from the nerves in the ear, but when they get these benign tumors arising from both nerves to both ears, it's a specific condition called neurofibromatosis type 2. And it's actually, with these two combined, there's some of the most common genetic tumor disorders, or genetic disorders in general, that we see in humans. And so we see a lot of both of these tumors, tumor types in patients in our brain tumor center. So these are just some representative pictures of the broad categories of tumors that we see. Again, it may or may not seem like a lot of different types to you, but actually within each one of these tumor types, there's probably dozens of different subtypes of each one of these broad categories that I just showed to you today. So what happens? So how do people present? Like, how do we find out they actually have a brain tumor? And if you imagine, your brain and your spinal cord really is who you are, and it really controls everything that you do. So it would actually be very complex to figure out if a person has a brain tumor or not. So really the way you think, your perceptions, your sensation, your movements, the expressions on your face, and the sensation in all of your extremities. It's all controlled by your brain, spinal cords, and all the nerves. So it may actually be fairly complex to decide if you have a brain tumor or not. But there's a few hallmark things that really indicate that someone has a brain tumor or not. So, for example, if we think about headaches, I mean, really, everyone gets a headache, and everyone has gotten a headache at some point in their life. And does that mean that you have a brain tumor? Well, there's 4 billion people in this world, and brain tumors are actually extremely rare. And the incidence of brain tumors is maybe 1/20th of all of the breast cancers that we see, maybe 1/50th of all the prostate cancers that we see, right? So a headache alone does not mean that you have a brain tumor. But there is a very specific way that a patient with a brain tumor presents with headache, and it means it's progressive and it's unrelenting, and it gets worse over a period of weeks to months, and it doesn't go away. So there are people who've had headaches for 2, 3, 4, 6 years. They get them 2, 3, 4 times a week, and then the next, what happens is they take a Tylenol or ibuprofen, and it goes away, they sleep it off, and then the next day they feel fine, they go back to work. 2 days later, they may get another milder headache, they take a Tylenol, it goes away, and then 3 days later they get another headache, and that's been going on for 4 years. And that's not a brain tumor related headache. Those things come and go, those go away. The brain tumor related headaches is someone who gets a headache maybe twice a year or 3 times a year, usually in setting of some severe stress, or maybe they drank too much one night and the next morning they had a really bad headache or something like that. But someone who never gets a headache and then they start developing a headache, take some ibuprofen, it really doesn't go away. It's gone, it's there the next day, it's there for 3 days, 4 days, and it's a little bit worse. 5 days, a week, and it's a little bit worse. And they're taking more ibuprofen, something is wrong with that person. It gets worse and worse and worse. And so that's very typical. And then that will progress to nausea. Sometimes they get such bad headaches that they get nauseous over a few weeks. That's a concerning headache to someone like myself or your doctor, that might actually be a headache that's a problem. You can have an extremely severe headache that knocks you out, you're in bed and you just can't get out of bed. Next day you're okay. 2 days later you're fine and you're back to work for the next week. That, in general, is not something that's going to signify a headache. But if you have that extreme headache and it doesn't go away for 3 days, 4 days, that's a problem. So the key here that it's progressive and unrelenting. Progressive means it's progressively getting worse and it doesn't go away. And then weakness. So a lot of people get weak, a lot of people feel weak. You get sick, you feel weak. Again, there may be times during the day when it's hot outside and you can't walk and you're weak, or kids kept you up all night and the next day you feel weak. That's different. So when we think about something that is a weakness related to a headache, we think about asymmetry. So it's just one arm, one leg, or one side of your body, or one side of your face. If that just happens, if that happens suddenly, and it's just, and it happened within seconds or minutes, and it wasn't there before, actually I'm worried about a stroke more than anything else. But let's say it's it's something that you noticed, but it wasn't too bad, and then a few days later it's still there and it's maybe a little bit worse, and a few days later it's still there and it's a little bit worse. That's more concerning of a tumor rather than something like a stroke, or just you're generally weak. That can translate into walking problems, hearing loss. That's totally unexplained. So as we all get older, we lose our hearing. That's just part of life. I mean, if we did audiograms throughout life, the high frequency decibels that we can record, that we can actually detect, continually go down. And probably it's getting worse as with every decade, because now we're all sticking headphones in our ears and jamming the iPods to the max frequency, or the max volume. So basically everyone's going to have hearing loss. But if you have unexplained hearing loss, a little bit worse on one side or the other, or it's a little bit worse than the general population, that's an indication. Vertigo. So vertigo is different. So vertigo is a very specific term that's not dizziness. So dizziness, a lot of people feel dizzy for various reasons. You get up a little bit too fast when you get from the bed, you get a little bit dizzy. You feel a little bit dizzy because you're dehydrated and you went for a walk outside and it's very humid, you get a little bit dizzy. That's a little bit different. Vertigo means like when you were a kid and you're on that little spinning wheel and you get off and the whole room is spinning like this. That's vertigo. So if you get vertigo and you didn't do that, you didn't go on, go to the playground and go on a spinning, wheel. I can't remember what those are called. But if you get vertigo and there's no reason for it and it persists, that's something you should tell your doctor about. Confusion, personality changes, that may or may not happen a lot to a lot of people, but it can be actually quite difficult in older people. So someone older is relative, but if you're an older person, sometimes it's hard to tell if confusion is related to a lot of different things. But when we think about confusion and personality changes, if it's steady, doesn't go away, and then it continues to get worse over a period of weeks to months. And again, and lastly, vision changes. So really any vision changes that's unexplained, that's not just like things are a little bit blurred and I need to check and get a new prescription. It really, you should go see your eye doctor, because vision changes doesn't necessarily mean you have a brain tumor, but it can be a lot of different things. It can be an eye disease, which are far more common. And so, but vision changes would be concerning when it's not just standard blurred vision. And then classically, on top of all these other neurological symptoms, when we think about a person with a brain tumor, when we see on TV, they collapse and have a seizure. That's, that can happen. But surprisingly, with patients with brain tumors in general, it really only happens less than a quarter of the time of all patients with brain tumor, the way they present. So seizures, if you have a brain tumor, it doesn't mean you're going to have a seizure, and most patients with brain tumors do not present with seizures. So seizures are obvious, but again, most patients with brain tumors don't present with seizures. So that's, in general, a very broad overview of the different teams that are involved in the treatment of a brain tumor, the types of brain tumors, and generally sort of how they present. So what I'll talk about next is really then when we see a patient that we're suspected to have a brain tumor, what do we do about it? How do we treat these tumors? And what's the management paradigm? How do we think about them? And what this slide shows is really there's been an extra step in general that's been incorporated really just in the past 5 to maximum 7 years in the treatment really of all cancers, but particularly with brain tumors, is we've learned so much in the past 10 years about the biology of brain tumors and why they occur and the different types of brain tumors and why they're so different, that we really are now starting to incorporate that in our management of these patients. And it's really this step here that's so different than where we stood 10 years ago. So what we do, in general, when we see a patient and we suspect they have a brain tumor, the main diagnostic procedure is to get an MRI of their brain or an MRI of their spinal cord. There's a lot of other tests that we can do, like blood tests and spinal fluid tests and all sorts of other things, but the principal thing that we need is really just a brain MRI. It tells us so much. And if we suspect that they have a brain tumor, often these patients will need a surgery. And the surgery, basically to get the tissue, in terms of diagnosing what they have, we need a piece of tissue to make the diagnosis. Now, that can be a therapeutic surgery, meaning like take the whole thing out and maybe we can cure this patient, or just getting a piece of tissue so we can make a diagnosis. Now, what we do then is classically what we would do is take that piece of tissue, stain it, and look at it under a microscope. And the pathologist, that's really a whole field of medicine that is dedicated to this, and they basically look at it under the microscope and basically they determine, does this cell look like a glial cell and therefore it's a glioma, or does this cell look like a different type of cell and we can call it a different type of tumor. Turns out that is incredibly, the technical term is it's incredibly non-specific, meaning they're often wrong or they're often very, very vague because for various reasons. Because that way that they diagnose this is very subjective. It's very subjective upon what the person who's looking under the microscope thinks it looks like. It's really not a very objective way to diagnose a person with a cancer. And so what we've really moved towards is what we call a molecular or a genetic diagnosis. So what we do is we take that piece of tumor tissue, and just like in forensics, we can just basically grind it up, look at its DNA, and the DNA will actually tell us what kind of tumor it has. Now, it actually seems fairly obvious in retrospect today, but in reality, that's such a shift from the way we've diagnosed tumors for the past 100 years. It's actually been a little bit hard to incorporate in practice. But what's different here, actually, at NYU is we've been early adopters of this. Some of our neuropathologists have been on some of the leaders in doing this molecular diagnosis, to the point where really we just use the molecular diagnosis when we make decisions on treatments with patients, and almost essentially replacing the traditional way we classify patients. But that's really where the field is moving, and that's really the cutting edge. In reality, it seems a little bit retrospectively obvious, but it required a sort of paradigm shift in the way we think about brain tumors in general, about cancers in general. But it's really a result of a vast amount of discovery and research we've done over the past 10 years. So if we didn't have all this research over the past 10 years, we couldn't do this. We wouldn't know what genes to look for. We wouldn't know what biology determines what's one tumor versus another tumor. And when we have this, then we can make more informed decisions about the management that we offer to patients. So interestingly enough, this linear pathway will likely change probably within the next 5 to 10 years. It's quite possible that we take an MRI scan, discover that they would likely have a brain tumor, and we can kind of suspect what kind of brain tumor they have, and then go straight to this using something like a blood test. And we're actually developing that technology today as we speak. We're drawing blood from patients with brain tumors. Maybe we can detect some of these DNA mutations or other abnormalities in their blood, because we know that some of these brain tumors are very bloody and they probably shed some tumor material into the blood. The technology's gotten so good that the bottom line is it's feasible to test for some of these things in the blood, where it was completely unfeasible about 5 years ago. So we might actually even need to skip this step if all we need to do is make a diagnosis. It's quite possible that we might even skip all of this altogether if it gets to the point where we can make a radiological diagnosis with such accuracy, and that's one thing we're also doing, is we're developing really all sorts of MRI techniques that are going to be able to perhaps predict what some of these genetic mutations are that are defining these tumors. So at some point in the future, we might just be able to do an MRI and definitively determine what kind of tumor this person has, and then just move straight to the treatment, and maybe skip everything else that they need to do. Which these are all very real, tangible things that was really science fiction maybe 10 years ago when I started, in this field, or maybe even training. None of this stuff was, if you mentioned it, we'd think you were kind of crazy. This is ridiculous. No one would ever get to that point. We're actually at the point where some of this is actually feasible to test. And so once we have this information, we collect all this information, and then we make all of these different types of therapeutic decisions based on those molecular subtypes, because it turns out that that's what really determines the behavior of these tumors. So again, our treatment today here is now tailored to the biology of the tumors that we discovered in the past 10 years. Again, the radiology that's done here, we're continuing, and really across all the field of neuro-oncology across the country, is we're using MRI techniques not just to find the tumors and figure out where they are, but the next step is, can we actually use MRI to definitively tell us what type of tumor it is? Because right now, actually MRIs are quite good. I'd say they're about 95% reliable. If I see an MRI scan, and if they have very classic features, at the end of the day, what happens is about 95% of the time, I can just basically tell exactly what type of tumor this person has, and we just need the surgery and the tissue just to confirm it. But the problem is there's still 5%, maybe a little bit more, where we can't do that. And so with that 5% error, if we're going to subject this person to treatment with surgery or radiation or chemotherapy, we want to be definitive, right? So we want to be 100% certain what kind of tumor this person has. But I do think that at some point within the next 5 to 10 years, we might get to that point where we can just do an MRI and be 100% definitive of what type of tumor this person has, regardless of the subtype. Again, right now, what we're doing is using a molecular genetic diagnosis of these tumors. This is the tumor here. It's actually fairly subtle. It's this dark shadow in the frontal pole of this brain tumor. And basically, that is what is happening. We grind up some of the tumor tissue, extract its DNA, and basically subject it to a genetic test. I mean, there's several genetic tests, but and then this is essentially one representative patient. We subject it to its genetic test. It shows that it has some mutations that are very characteristic of certain tumor subtypes. We actually don't even need to figure out what genetic mutations it has, because it's been so automated, the bioinformatics, the computational capacity has gotten to be so automated that it just then spits out the actual diagnosis. It's truly what we're doing today. So you grind up the tumor tissue, put it in a machine, and the machine tells us what it is. And this is the confidence score, and it really just tells us that this is a glioblastoma. We didn't really actually need to even get to the point where we even need to look at the actual genes themselves. We just put it in the machine, and it just spits out a diagnosis. And what this is a completely non-subjective way to diagnose a brain tumor. Before, we had very, very subjective ways. We just depended on the person who was looking in the microscope to tell us visually that they think that this is a glioblastoma. And actually, it's actually been proven. There have been studies that have shown that that way of diagnosing tumor, the old way, is largely, is incredibly nonspecific. So there are some studies where they took patients from clinical trials and they had what we consider 4 expert neuropathologists, like world expert neuropathologists, and they de-identified, they anonymized all the tumor samples and just had all 4 diagnose every single tumor specimen in the trial. And the concordance rate, meaning the rate at which they agreed on a diagnosis, was less than 70%. And these are considered world expert neuropathologists. It means 30% of the time they just completely disagreed on the diagnosis. Now, if I drew a blood test, to check your anemia, if it was wrong 30% of the time, it would never get approved. It would be thrown away by the state certification board. It'd be like, this, you can't try to pass this. But that's really actually what we had for the past 100 years, and really still what we rely on. But this is, again, I stress that because this is really just amazing that we can get rid of all that subjectivity and just put a piece of tumor into a machine and it spits out the diagnosis. And really, and a lot of things in our life, in general, in the population are moving towards that way anyways. And it just seems to make sense that medicine should work that way as well too. So anyways, we actually do this. There's surprisingly not many top medical centers across the country that do this, but basically we're doing this for every brain tumor patient that we see. So once you get to the diagnostic aspect, how do we treat these patients? So, and again, I'm going to do broad strokes. Okay, there's very different ways to do each one of these modalities, but again, each one of these would take an entire course or 7 years of training. This is my one slide of neurosurgery, where it takes 7 years of training to become a neurosurgeon, but basically you have a tumor and you can take it out. This is the white area is a tumor, and here it is after the surgeon is done with this patient. But again, it's not that simple. But the surgery is critical, and it really doesn't just establish the diagnosis at this point, because at some point we may not even need it. We might just draw a blood test or even just an MRI. But it is incredible therapeutic value. So again, for a good subset of patients, a surgery will just cure the patient. You take that tumor out, just like you take a malignant melanoma that hasn't spread, and you do surgery with some margin and you cure the patient. There are brain tumors where you can do that. You take out the tumor and you've cured the patient. And the other thing is, even if it's not a curable tumor, so actually this one is one of the, quote, low-grade gliomas, the ones that are still considered malignant because you cannot cure these by doing surgery. This is actually phenomenal surgery, and what you see here, it doesn't really look like anything's left, but there are always tumor cells that are left behind after you do a surgery in a glioma. But aside from establishing diagnosis, the benefit of taking all of this out is that what you can see here is you see this little Mickey Mouse shaped structure. You see the brain as nice as 2 halves that are nicely symmetrical, except for this big hole here where the tumor was. But if you look here, before the surgery, this Mickey Mouse structure, which is called the midbrain, is being squeezed and pushed aside. This is what we call mass effect. And that's all the pressure and mass effect from this tumor growing. This dark area is actually a fluid-filled cavity within the brain, fluid-filled area in the brain. And it actually should look like this, very small, but actually because it's being squeezed aside, a lot of fluid's getting trapped and then accumulating, cause buildup of that fluid pressure. And when you do the surgery and relieve all that, all of the brain structures can relax back to their normal configuration, and all the fluid spaces go back to their normal configuration, even this fluid-filled area here. And the reason why it causes all this high pressure is because the brain is encased in a very special sort of protective shell called the skull. And so the skull is completely immovable, obviously, compared to the brain. So if something is growing in your brain, something's got to give, right? So, and that's the problem that happens in patients with brain tumors. So you can have very large tumors grow in your abdomen, but then really all it does is just push everything aside, even in your chest. But when that happens in the brain, it causes a very specific problem because there's no room in the brain for that thing to grow. And then the next sort of broad category of treatment that we use is called radiation. So it's radiation therapy. And really what we do is apply radiation beams to the brain tumor. And that essentially just kills brain tumor cells. The way we do that, we try to be as much as we can focused to the tumor with the best technology that we have. And here what you see here is they take pictures of the brain and they map, the physicists and the physicians and the technician map the area that they want to radiate with the high dose beams. And what happens is the patient wears either actually a frame where they actually drill, they screw in screws to your head so that you don't move, or they can form-fit a mask on you so that you don't move. The critical thing is when you're getting radiation to the brain, we're trying to target as precise as we can to try to avoid the other structures that we don't want to get radiation, because your brain, again, is very critical, right? It does everything that we associate with being a human being: your thoughts, your movements, your actions, your emotions, and your sensations. So we want to try to avoid as much normal brain as we can. So, and one of the things that can make that a problem is if people move. So we immobilize the patient, and then they go into big machines, and the machines are different types. This is one it's like a donut, like a CAT scan, but they can be various machines. Some of them are just tables with a big machine that just kind of goes over you. You don't actually feel the actual radiation when you're getting it. It's like getting an X-ray or any other scan. You just lay there. But they can do that, but radiation is not without other side effects, even during the radiation itself. So they can be done in various ways. They can be done radiation all at once in one day, or they can break it up into 3 days, 5 days, or even up to 6 weeks, where they give a tiny amount every single day. So that's one of the hallmark ways that we provide radiation. And why we would do radiation, it's really done for various reasons. Sometimes we do radiation because we can't do more surgery, and that's the only way we can treat this tumor, because essentially all the surgical options have been exhausted. Some tumors are actually quite radiosensitive, meaning they're exquisitely sensitive to radiation, and they'll just melt away if you give radiation. So we actually prefer to use radiation. Sometimes we use radiation because they synergize with our chemotherapy. So sometimes if you give radiation alone, they might have effect in the tumor. If you get it with chemotherapy, that might have an effect in the tumor. But if you use them together, it's not even just an additive effect. It might actually be synergistic, where the combination is much better than either one alone. And then sometimes we use radiation because we really have no other options. The chemotherapy we're using isn't working. They have no more surgical options, and there may be some evidence that radiation will work, so we use radiation to the brain. Of all of the modalities that we have for malignant brain cancers in general, the ones that we can't take out with surgery to this day, we're not at the point where we have a lot of chemotherapies that are that effective. So ultimately, radiation therapy is still the most effective non-surgical therapy that we have for most types of brain tumors, not all. So one of the specialized types of radiation that we have in general is something called the gamma knife, or radiosurgery. And so they're different. These come in different sort of names and flavors. Gamma knife. There's something called I can't remember. To be honest, I can't remember all the different ways that they name these things. But it sounds like it's surgery, but it's actually radiation. But it's given in a very specific way. They can be ultra targeted and given a high amount of radiation, a very small target at a very high dose. So it's excuse me, a very specialized type of radiation that we use for very specific types of brain tumors. Not for all brain tumors, but it can be incredibly useful for very specific types of brain tumors. And that's what it does. It really focuses the target exquisitely well, and it can give a lot of radiation in one very, very small dose at one fraction, we call it, or 1 day, sometimes maybe up to 3 or 5 days. So here's just an example of how they target this. So the yellow line being the high dose, and then green line is very, very low dose. So there's very little scatter radiation to the rest of the brain structures. And then we get to chemotherapy, and this is just our clinic here on 38th Street. That's a brain tumor center clinic. So actually, the chemotherapy is done here, right in this building. This is the main Perlmutter Cancer Center building where most of the different oncology disciplines sit and where we do infusions for chemotherapy. But basically, we've sort of outgrown this building already, and so we have a satellite cancer center over on 38th Street where 3 of our disciplines are, including neuro-oncology. And basically, we have an infusion center with infusion chairs, and we can do the outpatient chemotherapy here. And so this is part of the integrated center for all of the things that we do to treat patients with brain tumors. So principally, the radiation and the surgery is done at the main hospital, and the chemotherapy is done at the outpatient cancer center, but not just the chemotherapy. Most of our other services that we provide to cancer patients are done in the outpatient. So all, like the therapy, nutrition, rehab, social work, all of those other things that are involved in the patient care is done usually at our cancer center that's away from the main hospital. And we do have a specific children's hospital as well too that takes care of patients with kids with brain tumors. And they also have kids, as you know, have very specific needs that are beyond what we can provide for adults. And so they have all sorts of things that, special types of social workers, obviously. These kids are often there all day getting treatment, and their siblings are there all day getting treatment with them. And so they provide all sorts of other services for the kids so that they give them the best experience they can possibly have going through chemotherapy and radiation. So that sort of segues into some of the other things that we do for patients with brain tumors, and that is so critical for patients with brain tumors is really the supportive oncology, because one of the reasons why brain tumors are unique is not just that in particular they can be difficult to treat, but they result in often a very disproportionate, what we call disability, compared to the other cancers. So disability meaning like weakness or walking problems or cognitive problems, seizures, things that impact their ability to do their daily life. And so therefore they may need individual support, but not just that, there's an inordinate burden on their family members, their caretakers, to care for them, because often these patients are not independent anymore on very basic things like taking a bath or getting dressed or preparing the food. So they are more dependent than the average cancer patient on doing very basic things on their family members or their other support networks. So we do the best we can in trying to support all the services that patients with brain tumors need in order to be able to go through their therapy and live life. And not on top of that, not just getting the things that they need to get done, but oftentimes if they have cognitive issues as well, they really are more reliant on their loved ones or their family members or their friends to help make decisions for them with regards to what treatments they need or the medications that they're taking. So the supportive oncology in general is the need for it is great in cancer in general, but really it's disproportionate need in patients with brain tumors because of the disability that they suffer. And the Cancer Center here has a number of other types of therapeutic options for patients with brain tumors to try to help them get through the treatment and living with a brain tumor. That's sort of a general picture of what brain tumors are and how we treat them, okay? But getting to more specifically about what we're doing today with a brain tumor patient, and again, the problems that we're having with patients with brain tumors, because at the end of the day, most patients with brain tumors suffer disproportionately, not just because of the dysfunction, but because of the outcomes. I'll get into a little bit about what the issues are and how we're trying to address them with research. So today, when we talk about the true malignant brain cancers, most of them are still lethal. So this is a comparison of all different cancers and the incidence rate, meaning the number of new diagnoses per year per X number of patients, and the mortality, the number of deaths per year per diagnosis. And so and this graph sort of splits them up by the type of cancer. So we can see here immediately, there's some cancers that are far more common than brain cancer. So breast and prostate, 20 times more common than brain cancer. Colon cancer, lung cancer, much, much more common, somewhere about 5 to 10 times more common. So there are many, many, many more of these types of cancers than there are brain cancers. And when I say brain cancers, I'm really principally talking about gliomas and medulloblastomas and a few other rare brain cancer types. But in red, so that's the blue lines, that's the incidence. In red is the number of people that actually die from their cancer every year. And what you'll notice is that there's tons of prostate cancers, but proportionally few of them die from their prostate cancer. And similarly with breast. And again, still, though, not to say that they're not a problem, because if you think about all the patients that die per year with breast cancer or prostate cancer, it's still more than all the patients that have been diagnosed with brain cancer. But what you'll see is, if you compare the blue and the red lines for each cancer type, the bottom line is most people that are diagnosed with their brain cancers die from their brain cancers, whether it's within 1 year or 8 years. Most patients die from their brain cancers. Really, it's the only comparable cancer is pancreas cancer, which has essentially the same mortality rates. Lung cancer also is pretty bad, but actually lung cancer is one of the cancers that today, that was published in 2012, which is 5 years ago, in the development cycle of cancer drugs and cancer, that's ancient actually. So probably since 2012 for lung cancer alone, there may have been somewhere between 8 or 9 new drugs that have been FDA approved for lung cancer, and it's making a dent in this mortality rate. So we're really improving in lung cancer. We have a ways to go in brain and pancreas cancer to really help these patients that are diagnosed with this disease. And why do patients die? Again, as I mentioned, so glioblastomas are the most common type, unfortunately the most common type of brain cancer that we see, and really the most deadly. And one of the reasons is because, as I mentioned, they don't spread to the lung and liver and kill people, but they can spread throughout the brain. They have this propensity to do what we call infiltrate. So they really invade and infiltrate widely throughout the brain. So this is a patient who is showed up at initial diagnosis. So this is the first time that he had an MRI to discover his brain cancer. And what you'll see here is just sort of a picture from up top here and a picture from a little bit farther below. And all of this white stuff is basically individual tumor cells infiltrating throughout the brain. This is one side, it's infiltrating onto the other side. And then if you do take a picture a little bit lower, it's really sort of clustered down here, but this whole lobe of the brain has been infiltrated. This has been infiltrated, it's been infiltrated on the other side. And this is just the glioma that we can actually see by the MRI scan. If we could actually have a better picture where we can actually somehow detect each individual cell, what I can tell you, and we do that sometimes at autopsy, we are able to actually do that and just basically section every part of the brain so after a patient passes away. But in this patient, if we were able to do that, do some sort of picture where we can look at every single tumor cell in the brain, we'd see tumor cells everywhere throughout his brain. So obviously this is not a surgical problem. If we had to do radiation, we'd have to give massive doses of radiation to the entire brain, which a person really wouldn't survive, and if they did survive, they wouldn't be a human being anymore. So this is the problem that we're dealt with, this diffuse infiltration. And oftentimes, if it is more focal, so this is a little bit more focal, meaning it's a little bit more sort of circumscribed rather than being widely diffusely infiltrative, they often happen very deep. So this is right in the middle of the brain. We can't take this out. Most of it's going to be left behind. The best we can do is try to treat what we see with radiation and the chemotherapy that we have. And this is all the swelling around that. This is the tumor, and this is all the swelling that occurs around that tumor. And on top of that, to add another degree of difficulty for that these tumors do for us, is when you see that, even that sort of widely infiltrating thing, they're not all the same tumor cells that are infiltrating throughout the brain. And this is something that we've learned all too well over the past 5 years as we learn about this DNA technology, is that each part, so this is a brain at autopsy who's not been treated. And what happened, this is a main tumor mass, and this is another tumor mass, But basically, all these squares was where the pathologist just took sections of the brain to see if there were tumor cells. And what they found were, yes, they found tumor cells in all these areas that didn't look like they were affected by tumor cells, but they were all there. But not just that, the scarier thing was we just looked at 3 genes. We have 20,000 genes, but we just looked at 3. And they're different colors here, orange and green. And there's another one that's not shown here, but we looked at 3 genes. And what you see is they're different tumor cells. So this one has a lot of this orange gene we call amplified. It's just jacked up the level of this gene to such high degree, and that's why it's growing so fast. But the adjacent cell has a completely different gene jacked up. And then if you go around and just start sectioning different parts of the brain, it's a different gene in each one of these parts of the brain. And so if we had a drug and it killed this part of the tumor, oftentimes it does nothing to the other parts of the tumor. So that's what we call heterogeneous, and that's what we're faced with when we try to deal with developing a drug for these tumors. And so that's the malignant brain cancers. And then this is just to highlight the benign tumors that we see that are problematic. And again, this is just an example of the ones that become lethal, even though they're benign tumors. This is a pituitary tumor. This is the pituitary gland, should sit right here. But as you can see here, it's outgrown the pituitary gland, and it's encased major blood vessels in the brain. What you can't even see here is there's nerves to the eyes that are responsible for vision, and basically they're completely encased. You can't even see them. And this person's gone blind from the growth of this tumor. And again, we also see is these fluid-filled spaces are starting to get a little bit big, and that's due to all the pressure in their brain. Here's another patient with, we call a benign tumor called a meningioma, but occasionally these meningiomas just occur and they spread throughout the brain, and they just cause multiple nodules all throughout the brain, and ultimately lead to the demise of the patient. So these are all things that we occasionally see in patients with brain tumors. So how are we combating this? The bottom line is we have to learn more about them and then try to develop better therapies than we have. I mean, radiation surgery, we're realizing has its limitations. The current generation of drugs that we have just isn't doing what we need it to do. So we need to move to other more novel types of therapies. And so with all of the genetic knowledge that we've learned, all the DNA-based knowledge that we've learned, we learned a lot about the biology, what drives these tumors, what makes them grow. And now can we target all those little things that drive these tumors and make them grow? So the real advances that have been made in other cancers have been these 2 types of therapies, what we call gene-targeted therapies and immunotherapies. And really, in some of those other cancers, we're making remarkable inroads. I actually just saw a woman, she's now 75, I share with one of our lung cancer doctors. She's sort of the poster child. Well, I mean, 75 is not a child, but maybe in some circles it might be. But she's 75. She was diagnosed with lung cancer 4.5 years ago, metastatic lung cancers all over her body. But basically, they were able to do just a biopsy, a needle biopsy, and find a gene in her tumor that's causing her lung cancer to spread. And there are now drugs that are effective at treating that gene, that drugging that particular gene that's causing her lung cancer to spread. And she got on the drug, and basically everything melted away. She never got chemotherapy, she never got a big surgery, she never got radiation. And she did extremely well for about 2 years, and then the cancer grew back. And what we're able to do now is to then biopsy the cancer that came back and determine what happened. And so what we found out is that same gene developed a resistant mutation. So it's like bacteria. So like when you give someone an antibiotic with an infection, and if you give them sometimes too much, or which is the case. I mean, if you keep giving the person the same antibiotic, eventually the bacteria that it's treating is going to become resistant to it and figure out a way to grow against it. And then you use a 2nd generation antibiotic and then a 3rd generation antibiotic. That's essentially what we're doing with some of these cancers. So she got on a 2nd generation gene drug, basically developed to hit that resistance mutation. And that was about 2 years ago. And then she was fine for 2 years. And then, so 4 years along, all she's had was a pill that she's taken every day that really didn't cause any side effects, and she's living a normal life with metastatic lung cancer. But unfortunately, what happened is it came back again. And this time when it came back in the brain. And when it comes back in the brain, it came back in the fluid in the brain. And historically, when it comes back in the brain, that was basically the end. I mean, we never really had anything that worked when it goes into the brain. And so this is literally just a couple of months ago. What we know now is that the brain, that surface, the meninges, protects the brain and spinal cord from bad things it doesn't want to get in. So it actually either blocks it or pumps it out. And so what we did was we just jacked up the dose. We just doubled the dose and just see what happens. And then this has actually been tested in some clinical trials, so we knew that there was some precedent for this. And so we doubled the dose, and then now all her brain lesions are shrinking. And so that we just got the MRI about last week. And so even with brain cancer or lung cancer that's spread to the brain, in what we call, the technical term is a leptomeningeal spread, which is the cancer cells are floating around all the fluid. She's actually had another response, and she's now living a normal life. She's actually going on a trip for 3 weeks. I think she's going back to China. I think on a trip for 3 weeks, and she's like essentially living a normal life. And you'd never know she's had lung cancer, metastatic, that's spread to her brain, and all she's been treated with has been a pill that she takes every day. So she's sort of the poster child for where we should be with cancer. Now, that's my goal. That's our goal as a brain tumor field, because actually today we're not anywhere near that. But that's a demonstration that that's where cancer can be. Immunotherapy is another really landmark success that's happened in cancer in general, but really only in a few cancers where it's been a success. But in the few cancers, the real poster child cancer for immunotherapy has been melanoma, which is a cancer of the skin. When I was in training, melanoma was as bad as metastatic melanoma, meaning when melanoma spread throughout the body, it was as bad as having a glioblastoma. The survival rates were the same. We had no drugs that really worked. Most people died within 6 to 8 months with metastatic melanoma. Not most, about 98% of people with metastatic melanoma died within 10 months. And that's, when I was in training, that was reality. Today, they're potentially curing with immunotherapy up to a third of patients with metastatic melanoma. Some of the patients on those original clinical trials and these immunotherapies 10 years ago are still alive without any evidence of disease. And they had metastatic melanoma. So really, we've really encroached upon, in the past 5 to 10 years, some transformative therapies, things that when I was a medical student, I just thought never would have existed. I'm like, at the time, I was my whole principle was try to get the cancers before they turn into metastatic cancers, and that's the only way we're going to have a chance, because by the time it's metastatic, we had no chance, and we'll never be able to do anything for these cancers. And today, that's just not the case. And so that's our goal. That's where we're leading to. We're not there with brain cancers. We're doing a ton of research, and that's building. And I think in my career, I should say, I don't think that the treatment for patients with malignant brain cancer is going to be the same as it is today. And if I really believe that was going to be the case, probably wouldn't be doing this, but I don't believe that's the case. I really do believe that at some point within the next 10 to 15 years, we're probably going to stumble upon a sea change in how we're treating these patients and really make an impact. And we do that by doing laboratory research and clinical trials. And I'll talk just a very last few slides, I don't have that many more, talk about some of the things that we're doing. One of the things that we've developed is much better models. So in order to test our drugs, we need to have a good model to test it in. So we can't just develop a drug and then take it into a patient, because we have no idea if any indication, not just whether it will work, will be horrifically toxic or it will actually make the cancers worse. Now the problem is we have never really had very good representative models to test drugs in, and we're getting better. Now we still don't have perfect models, but we're getting better and better. We're now using what we call patient-derived tumor models, where we can take the surgery specimen and grow them in such a way in a dish, really, that they really retain a lot of the natural characteristics of the patient tumor. It's a very special way that you have to grow them, and they will continue to harbor all those mutations that were in the original tumor, have all the microscopic features that the original tumor has, And then what we can do is we can then implant them in animal brains, really. And then when you look at the animal brains, they look like the patient brains. And therefore, we have a way to test them. We can do the genetic analysis, we can do drug screening, and that is a way that we can test all the novel drugs that we're coming up with after we learn about the biology of these tumors. Here's an example in a couple of years ago of some of these things that we did, some of the brain tumor models that we did to develop models that we can use for testing. So these are all, each row is an individual patient with a brain tumor. And what we did is in the surgery, essentially grow them a certain way and then implant them in a brain of a mouse. Actually, from here on out, these are MRIs of the human tumors, and these are all mouse tumors. And this is taken from a paper, so it's a little bit complex and you don't need to see all of it, but this is a special stain for the tumor cells. And you can see that the tumors grow in the mouse brain very much like it does in the human. So this one is a nodular tumor, but it has a little bit of an infiltrative tail. And this one does a very similar thing, where it's mostly a nodular mass, but what you can see here is it's got an infiltrative tail on multiple sides, and it's really truly acting like the patient tumor. Here's another tumor that's really less of a mass and more widely infiltrated. There's a little tumor here and a little tumor here, and it's going across here. And when we implant it in a mouse, you'll see that it really doesn't form a mass. It just widely infiltrates. All the brown is the tumor cells throughout the brain. Here's one that has a nodular component, but yet also an infiltrative component as well. So this is more discrete. And this is nodular with an infiltrative component. And that does the same thing in this mouse, where it's mostly nodular, but that does certainly have an infiltrative component. And then here's one. This is why this patient's tumor is very nodular and really just grows as discrete sort of balls in the person's brain. And it did that in the mouse as well, too. It really just formed very discrete nodules in the mouse. So what we have now is we can develop models of patient tumors that are going to more closely recapitulate the patient tumor, so that we can test our drugs and see if they're actually working before we take it to a patient, basically. And we can also use these to screen different drugs and see if we can find a drug that actually works. So those are the models. Now, just talk very generally about immune therapy for cancer. And this is a little bit of a complex slide, but probably the most important thing is just this slide. And what is immune therapy? So the immune therapy in principle is we're just basically trying to boost the immune system somehow to recognize the cancer cell as being foreign and to eliminate it. All right? So the immune system is incredible at doing that. So that's how we get rid of infections. Most of the infections that we get exposed to, we clear naturally through our immune system. And even infections that we get where we need antibiotics, most of the work is still done by the immune system. The antibiotic really helps that. It really initiates the process, kills off some of the bacteria, but then the immune system takes over. So the immune system is incredibly good at defining what's normal and self and versus non-self. Now the problem with cancers is that they're not normal, but they're mostly yourself. They come from your own tissues, your own cells. And so most of it is normal, but yet it's growing abnormally, so there's something abnormal about it. But because of that sort of soft interface, the immune system often can't really detect it. It can't see that it's abnormal, and so it leaves it alone. And there's a number of ways that it does that. So if your immune system was too jacked up, it would start attacking all sorts of organs and cells in your body. So it has to have a system where it's sort of figuring out, like, well, what's normal, what's not, when it counters all your cells. And the way I think about it is there are a series of checkpoints, and there's it gets very, very complicated, but actually it gets complicated for me. And the simplistic way I think about it is it's if you imagine like a do not disturb sign on the hotel room door, right? So that's what, if you're a normal cell, you put up a do not disturb sign, and the immune cell would be like the hotel maid that goes by, and if the maid sees a do not disturb sign, it just moves on. And tumors have hijacked that system. They put up multiple do not disturb signs, and then the immune cell kind of comes by and says this is normal, and it just moves on. What we discovered all those little signs, and now we develop drugs that basically just take off those do not disturb signs. That's a simplistic way to think about it, but in a lot of ways that's really how it works. And so that's what these inhibitors are. This is the tumor cell. This is an immune cell. These are other immune cells, and this is a do not disturb. And basically, these drugs just take off these do not disturb signs, and then this immune cell can go and attack the tumor. What this slide is complex because it's not quite that simple. There's multiple do not disturb signs and multiple other players in the immune system that help it or dampen it, and there's all these signs. But in principle, that's kind of how it works. So by taking off one do not disturb sign, it's led to cures in a good subset of melanomas. And so we're trying to adapt that to patients with brain tumors in various ways because there's all these different things that we can potentially try to target. And these are the things that we're developing in immune therapy and cancer. And right now, we are testing the same drugs that we're using in these other cancers for patients with brain tumors. We're not having the same level of success, but it's probably just going to be figuring out the right signs to target, the right combinations, and the right patients. So one drug's probably not going to work for this patient. We're going to use this drug for that patient, et cetera. So there's been some examples in the literature now where we've seen some success. So here's a paper that they did actually find one drug worked in a couple of patients where basically they saw just one of these immune drugs lead to remarkable regressions. And this is how early this is. This is a paper that was published in a major oncology journal just last year. So, these are the first successes that we're actually seeing in brain tumors. So we're hoping to build on that success because right now it's just isolated patients that respond. It's not 30%, it's not 10%. It's just an isolated patient here or there that will see this. But we do start seeing this. We have started seeing this in brain tumors. And building on that, just to kind of plug ourselves, we do have these immunotherapy clinical trials for patients with brain tumors here, at NYU. But bottom line is, when these patients get chemotherapy and radiation and they come back, we're using these immunotherapies in combination. So the immunotherapies that we're using now are the immunotherapies that are being tested in these other cancers, which again, we're only seeing isolated cases, but what we're trying to do is combine it with other things like radiation or other modalities, see if we can improve upon the successes of the early generation trials. So those are the two broad categories that we're using now to try to improve upon all the chemo that we have today. And again, I think based on the foundation that we have and the successes that we've had in other cancers, I really don't believe that we're going to be sitting talking about the same drugs in 5 or 10 years that we're talking about today. So really that's it. I'll just end up with a few concluding remarks, and then I'm happy to take any questions. Bottom line is, we really, to take care of a brain tumor center, it needs to be comprehensive and multidisciplinary, really take care of so many different aspects of the needs of a brain tumor patient. It requires multiple specialties, multiple disciplines, not just from the MD perspective, but across all the different therapeutic modalities. And what we really have offered now is really cutting edge diagnostics. We've really learned so much about the biology, and we've adapted that into really precisely defining what each tumor type is. And then the next step is to be able to find effective drugs for each one of these individual tumor types. And really, we are on a mission here. We've really generated a lot of resources, or expended a lot of resources to really bring in top-level researchers, and both in the lab and in the clinic, to develop new therapies for patients with brain tumors. And that continues to be our mission. And again, I think that's the kind of thing that's going to drive the better treatment paradigms that we have for these patients. So with that, I'll end and take any questions if you have them.